Joe, can you start that?
Recording.
And let me stop sharing and you can share.
Share screen, hold on. I think you can see it, right, Greg?
Yes, sir.
Hold on. Are we good?
Yes, sir.
I'll
I'll
pause for a
introduce you
moment.
here in a second. Well, welcome everyone, and I have a pleasure here of introducing my friend, colleague, and partner in optometric education consultants, Dr. Joe Salka. Joe served as a professor of optometry at Nova Southeastern University College of Optometry. He was there for 28 years and 2 days. He served as the chief of the Advanced Care Service, the director of Glaucoma Service, and the chair of the Department of Optometric Sciences. Joe also is a founding member of the Optometric Glaucoma Society and the Optometric Retina Society. Joe also is the chair of the Neuro-Ophthalmic Disorders in Optometry for the American Academy of Optometry. Joe doesn't stop there. Joe's a gifted writer. Joe has hundreds of published articles. He's also the lead author of the annual Handbook of Ocular Disease Management, and that is by Review of Optometry. Joe is a well-known lecturer and international lecturer. And recently, Joe has moved to Sarasota, Florida, where he and his wife, Lori, are with the Center for Sight. So with that, everyone, please give my friend, our colleague, a big virtual round of applause. Joe, take it away.
All right, thanks, Greg. Tonight's topic, second thoughts on secondary glaucomas. These are my disclosures within the past 12 months. I have been a consultant, Speaker Bureau member, advisory board member for Zeiss, Visus, and Bausch and Lomb, but I've got no financial interest in any product. I have created this presentation solely on my own. There's been no outside influences. So why is it secondary? Well, it's secondary to some other condition. These are about a third of all the glaucomas. Inflammation, neovascular disease, neoplastic disease, lens-induced disease can all cause this to happen. Now, these are potentially curable if the underlying cause is treatable. People are usually younger than primary open-angle glaucoma patients, and the angle can be closed or open, depending what type of glaucoma we're talking about. But knowledge of the angle status is very important because this will dictate the management. It's important to take that view from 30,000 feet where we can look at everything. And there are so many potential causes of glaucomas that can occur secondarily that we can't talk about or remember every single one. But if we know what the angle status is, it will prevent this going down from the primrose path of mistreatment. So that's the most important thing. Now, we also sometimes use the term glaucoma cavalierly. From trauma or inflammation, the pressure may go up significantly, yet because of the temporal nature or the short term when the patient comes in, there may not be any damage yet to the nerve fiber layer or visual field. Yet we call this glaucoma because we know in our best medical opinion, if we do nothing, these glaucomas changes will occur. So they may not actually truly merit the diagnosis of glaucoma. They may just be a secondary pressure rise, but our belief is it's going to it'll get worse if we do nothing. Now, there are some common secondary glaucomas that we're pretty familiar with, and we need to really delve and review, I think. There's pigmentary, which is an open angle. There's exfoliative or pseudo-exfoliative, whichever you prefer. I prefer the term exfoliative. The angle is nearly always open, but in rare situations, there can be a pupil block and angle closure. There's early and late traumatic glaucomas where the angle can be open or closed depending on what the mechanism. There is a steroid-induced glaucoma, which is open, the angle is open. There are lens-induced glaucomas where they can be open or closed. There's neovascular, which is predominantly a closed angle situation. And inflammation can either have an open or a closed angle, though typically I would say in about 2/3 of the case, the angle is actually open with inflammation. And then we get the best of the rest. There are miscellaneous causes where the angle is open or closed, after retinal detachment surgery, particularly when scleral buckles are used. If silicone oil is used, these are all potential open angle or elevated IOP situations. Systemic disease-related conditions, drug-induced pressure rises, episcleral venous pressure elevation, either idiopathically or from some conditions such as cavernous sinus fistula, sideritic glaucoma, which is an open angle situation that often happens post-penetrating with metallic foreign body, and just so many other numerous potential causes. Now I'm going to start off with what I call the case of the resident misdirection. There's an aqueous misdirection syndrome, also known as malignant glaucoma. This is not quite the same thing. This is a situation where one of my residents at the time, when I was at the university, saw a patient. He was moonlighting on the outside and brought him into our glaucoma service. And he presented the case. I was helping him manage the case. And he had a thought in mind, which I initially supported until I actually really took a look at the patient and realized, he is misdirecting. It was a 60-year-old Hispanic male coming in for a complete eye examination, 20/20 in each eye. Ocular history, he had ocular trauma at 7 years old, but I'm going to tell you, this was vague and kind of forced by my resident. My resident, he's a very, very sharp guy. That's why I really enjoyed working with him, really listened to what he was saying. And, he may have been like hit by a stick or scratched or something, but, there was no really true history where, I had blood in my eye, I lost my vision, I was hospitalized. There's nothing like that. Pressure is 15 right eye, 38 left eye. Gonioscopically, I got to admit, it was a funky looking angle. It was very, very deep. And, he looked at it, he brought it in as an angle recession glaucoma. Now, this angle recession glaucoma, left eye, an apparent unilaterality, and this, very vague history of trauma kind of pulls it together. But one of my clinical pearls has always been 40% of angle recessions or angle recession glaucoma is diagnosed by imagination only, where there's an asymmetric or unilateral situation. It's the first thing that comes into one's mind. Is there a history of trauma? Maybe there is, maybe there isn't. It's not really all that compelling. And then, they look at the angle, and sometimes angles go a little bit wider and say, yeah, it's possible angle recession. Patient comes back for next follow-up, possible angle recession. Third follow-up, now the patient's got angle recession glaucoma, and they may or may not have it. So this is what he looked like. These are healthy looking nerves, so the pressure really hasn't affected. Maybe there's some faint nerve fiber layer defects here, but the tessellated fundus makes it a little difficult to assess it. Then we take a look, and the OCT is rather robust in the right eye. It is not as robust in the left eye. Maybe there's a bit of inner eye asymmetry. We can see a more pronounced nerve ganglion cell complex in the right eye, much more sparse in the left, but not quite with that nautilus shell appearance or horizontal cut at the raphe. And actually, if we look at it, the uninvolved eye has a better visual field. The involved eye has a better visual field. The uninvolved eye has a worse field, but I'd probably say when we go back and look, that's probably real field loss in that left eye. That corresponds to the lack of robustness of the nerve fiber layer and the ganglion cell complex. And yeah, we go back and you see, yeah, that probably really is a nerve fiber layer defect. So we're going to call this a glaucoma. And when we take a look, and I can tell you, it was really very, very deep. I mean, there was a lot of ciliary body there. And it was 360 degrees, very symmetrical. And the other eye didn't quite looked at like that. But what I did notice as I was looking, I was very impressed at how deep this chamber was the real darkness of that pigment right there. And even the trabecular meshwork anteriorly had a fair amount of pigment, and you can certainly see it all the way around. And while I was listening to him and believing that we're dealing with angle recession, that kind of really caught my attention. So that brings me to polling question number 1, Greg. Do you want to launch it or do you want me to launch it? Okay.
You got it.
So what's the most likely diagnosis? Is it exfoliative glaucoma? Is it pigmentary glaucoma? Is it angle recession glaucoma? Is it primary open angle glaucoma? And if you can't see what is out there, you can actually, left click and move that poll if you want. I don't know, I don't think you've ever seen this, Greg. This is actually Hobart, Tasmania. It is a nice little harbor town, the biggest city in Tasmania. This is the view from my hotel, a lovely little harbor town. I've been there 5 times, and I think that might actually be a world record for a non-resident of Tasmania.
So everyone knows the 6:45 email had the handout, but it's also in the chat box. We have, well, they did well, Joe. I'm going to end it.
All right.
I'm going to share it. And there are your answers.
So people are following along with my resident that this is angle recession. More people are actually thinking it's pigmentary. And when I actually looked at that pigmented meshwork, I sat back and said, let's re-examine this. And I pulled back, and there was pigment on the endothelium, and we had our classic Crookenberg spindle there. And you're not going to be seeing that in a patient with angle recession glaucoma. And we can certainly see a very, very large, very deep angle. It was unilateral. We got the pigment on the endothelium. This was the uninvolved right eye. We can see the iris is very planar. And we take a look at his other eye on OCT, you can actually see the concavity and the iris is bowing backwards. And that mid-peripheral iris is rubbing against the lens zonules. And that iridozonular friction is leading to pigment being released, depositing on the endothelium, on the lens, and ending up in the trabecular meshwork. So this was actually a very interesting case of unilateral pigment dispersion syndrome leading to pigmentary glaucoma. We can see a very flat planar iris and a very concave iris right there. So this is a secondary open angle mechanism. The angle is open. It tends to be in younger myopic Caucasian males. It does happen in females as well, but men are the ones more prone to truly develop glaucoma. Now, it can occur in patients of African descent. These are often middle-aged women of color, 45 to 55, 53 years old. And it's a little bit of a different appearance. The iris tends to be planar, not concave. Translation defects are relatively rare or not present, and there's really minimal corneal pigmentation. So your diagnosis really comes gonioscopically when you see that really, really thick trabecular meshwork pigment. It is typically bilateral, but it may be asymmetric. I have seen unilateral cases. Obviously, this is one nice case right here. And pigment dispersion syndrome is obviously the precursor. There's about a 50% conversion rate to pigmentary glaucoma over one's lifetime. And part of the reason for that is it is a disease of younger people. I would say that I probably came, when I was at university, I probably came across one case of at least pigment dispersion syndrome in every other class of students. Usually I picked them up in their second year. Some people actually went on to glaucoma. Some, I don't know if they ever developed glaucoma. But when you have pigment dispersion syndrome in your 20s, there's always a very good chance this could lead to glaucoma. And these have a higher diurnal ILP fluctuations. You may miss the pressure elevation on a single exam. That's why I think a person with pigment dispersion syndrome probably should be pressure checked at least every 6 months if everything initially is okay. Now, I'm gonna stress to you, it is not physical blockade by the pigment. That doesn't do it. Now, there are situations if there is a sudden release of pigment into the anterior chamber, there can be a mild transient pressure spike. Nothing really significant. But really what is happening is the trabecular meshwork is trying to phagocytize and clean out that pigment. And the endothelial cells are working away. They are trying to digest that pigment. And over time, that leads to a degradation of the trabecular meshwork. It loses its ability to process aqueous. There's collapse of trabecular beams. You get a certain scarring and sclerosis of the meshwork. And it's actually very similar to the mechanism of angle recession. It's a degradation of the trabecular meshwork, albeit this is pigment that is being digested. It isn't a huge blockage, though. It's not that it's blocking the trabecular meshwork. It does transiently. It's the wear and tear trying to clean it out that causes pressure to elevate. So we have these concave irises in the classic situation, and it is sometimes called a reverse pupil block. And what has been shown through ultrasound biomicroscopy that some phenomena involving accommodation and or blinking traps aliquotive aqueous in the anterior chamber. So there's actually a higher pressure in the anterior chamber than the posterior chamber, causing the iris to bow backwards. In angle closure, true angle closure pupil block, it's iris Bombay. It's a steep iris. This is a concave iris, and it forces it to rub against those zonules, and that's where the pigment is coming from. Gets caught in the aqueous convection current. It is laid down on the anterior and posterior surface of the lens. It's on the trabecular meshwork and on the cornea as well. So this reverse pupil block seems to be involved in this mechanism. And these are patients that are going to have a really very deep, bowed backwards iris. It usually is a spindle formation. It can be diffuse. If you're looking at diffuse pigmentation, you may actually be looking at pigmented gutata. It doesn't have to be a spindle, but typically it is. Now, when you see that spindle or any endothelial pigment, you should transluminate the eye and do gonioscopy. Gonio is more definitive transformation of the iris. They may not be present. It depends on the thickness of the iris. But they're radially located in the mid-peripheral iris. And again, as I said, it is not directly related to the pressure, the pressure elevation. And these are all things we're going to look for. The Krukenberg spindle, and it tends to be vertical. The mid-peripheral radial transformation defects, and there may only be one or two. So you have to be careful to look and raise the eyelid up. Now, this one is very characteristic, and sometimes we easily miss it, but it's called a Shays line. When we have heavy pigment on Sample-Leslie's line, that's on Schwalbe's line, we call that Sample-Leslie's line. This is a Shay line. It's a circumferential pigmentation, mostly on the posterior, but also on the anterior surface of the iris. It is very far peripheral, very hard to see biomicroscopically. I usually see these during the peripheral examination with the BIO. And what happens is, as I'm doing peripheral exam, I'll come across, I'll hit a shadow on the peripheral retina because this will cast a shadow. Very far out, hard to see biomicroscopically, easier to see gonioscopically and indirect ophthalmoscopically as well. And another nice example, sometimes if you get all the way out, great dilation, you can actually see some of the zonules. You may get that Shays line. That's very pathognomonic of a pigment dispersion syndrome. Now, this is actually one of my former students. I would like to catch up with him to see if he ever converted to glaucoma. Because here he is, it is strictly unilateral. He had translation defects. In fact, this is his eye. He had heavy pigmentation in one eye, no pigmentation in the other, no translation defects, no Kirkenberg spindle. And what was the difference in intraocular pressure between these two eyes? Nothing. There are 15 in each eye. So the fact that it's heavily blocked does not prevent aqueous from being processed. It's the degradation trying to clean it out. I think we just talked about this. Now, I'm going to share with you a historical factoid which we all learned. It's the patient who has blurred vision while exercising. You know, patient is playing basketball, patient is doing something physical, they have pressure, they have blurred vision, hazy vision, halos around lights, meaning that pigment is being shaken loose by this activity. It's causing a pigment dispersion syndrome. The pressure goes up, shuts down the sodium potassium pump. They get corneal edema, causes pressure to go up. Greg, have you ever seen this happen?
I have not, Joe.
Nor have I. I've known a number of clinicians and researchers who try to get this duplicated, and they really weren't able to do it. We all had to learn it for national boards. What I want to tell you is this all came from a single case report in the 1960s. So from one case report in the 1960s, we got a board question, and we got a question that often would get asked in interviews for residency, and it was a single case in the 60s. Understand?
It's a case of something that went viral, huh?
Exactly. Before the internet. Understand, it's an urban legend. That brings me to polling question number 2. And Greg, here's my dog. You recognize my dog? This is Mason, right?
I don't recognize that being Mason, but
it kind of looks a little bit like him. So which medication should be avoided in pigmentary glaucoma? Beta blockers, prostaglandin analogs, miotics, carbonic anhydrase inhibitors, or rho kinase inhibitors? And no, this is not my dog. Well, they're about the same size and somewhat of the same temperament. This is actually a marsupial. This is a Tasmanian devil. Were you aware of that, Greg?
I was not.
Yeah, this is a true Tasmanian devil, looking nothing like the cartoon character. They only made that cartoon character because the Tasmanian devil does have a ferocious howl to it. And they are the best accomplices to murder that there is, because a body dumped in Tasmania, in the wilds where Tasmanian devils are, will be completely devoured, skin, hair, and bones.
Let's see if we can get one more. Let's let this person in.
Think how much people are learning tonight about Tasmanian devils.
About that, yeah. And people are going to be saying, "Hey, honey, let's go to Australia." You're giving them bad thoughts, Joe.
But don't get a Tasmanian devil. They're not good pets. So what should be avoided? Some people say beta blockers, prostaglandin analogs, miotics, carbonic anhydrase inhibitors, rho kinase inhibitors. Really, there's nothing that you can't use, though. I'm gonna say speculatively, I don't know about rho kinase inhibitors. Greg, what are your thoughts there? I mean, that is a trabecular outflow drug. What do you think?
I don't think there would be any harm to it. It's, it's working on the actin and myosin. So, you're talking about, you said phagocytosis changes to the cytoskeleton, it's not going to be a negative, I don't think, in any way. You might not get the effect that you're looking for, but it certainly is, should not, one of those that should be avoided. It's, you could go ahead and use it.
Yeah, really anything is going to be acceptable. Miotics are actually theoretically drugs of choice because it will pull that iris a little bit more taut, allow a more planar type of configuration, maybe get the iris off the zonules, but miotics, especially in young people, are just not especially tolerable.
Joe, before you move on, we have a question
Sure.
that says, do you recommend checking their pressure multiple times a day to check for diurnal spikes when you are first diagnosing a patient?
I don't know that I would do a diurnal pressure curve on the same day. You're gonna want to get a couple tests done as baseline so that you can follow it or somebody else in the future can follow it. I would say bring it back a couple times and just double, in 2 or 3 visits, you get your pressures. But I don't, it's nothing I think you're going to find anything. It's just the 6 or 12 months later, that 18 is now maybe a 27.
And Joe, I want to just kind of steal off of that question. The diurnal variation. So everyone out there, we're talking peak and then trough and then peak and then trough. Let's say that peak is at 8 o'clock on one day. And let's just say it's exactly 12 hours apart. It's 8 and then 8 and then 8 and then 8 a.m., p.m., peak, trough. It doesn't always stay at 8 a.m. What they found with the studies is that 8 can go to like 9 a.m., 10, 11, and it can just kind of shift back and forth. You do, for those people that do get the peaks and trough, it's not always at the same time. So you're peaking and troughing, but you're also kind of going a little bit left to right, 8 a.m., say 9, but say a 4-hour swing back and forth. So just don't always think that peak is always at the same time if you identify it.
That's an excellent point, Craig. And
And
these are
then,
oh, sorry, go ahead.
go ahead. No, this another question came in. So you go ahead and if you had a comment, then I'll read the question.
No, read the question.
Okay. Would prostaglandins have any negative effect since they cause increased pigmentation?
That's a great question. The answer is no. Prostaglandins work very well in these patients, and only about 10% of patients are going to have some increased melanocytes, but that's very deep in the stroma, so that's only a theoretical. PGAs work very well. The only one I have a question about are the Rho kinase inhibitors. We just haven't had them out enough that we have a good fund of knowledge to say they work or not. But don't worry about PGAs; they work very well. Be careful about SLT. SLT is a very good option, but in these heavy pigmented meshworks, there can be a paradoxical pressure spike where they actually spike much higher after the procedure. And there's always been the question about LPI. Well, LPI, putting a hole in, actually allows for an equilibration of pressure between the anterior and posterior chambers. It has been shown to actually flatten the iris a bit. It has gone in and out of vogue over the years. There really is no literature that supports the use of an LPI. And once the pressure has elevated, there's nothing we can do to stop that release of pigment that will have any effect. So LPI not recommended. SLT, good option, could have a complication. Any of the glaucoma meds are fine. And that's where we say we can actually go from a concavity to a more planar approach. Now, Greg, I'm going to move on to, unless there's another question or comment, the case of what I call the bad prognosis.
Nope, everything's caught up.
As we know from our experience, when we see glaucoma patients, they're generally fairly predictable about 90% of the time. It's generally a slowly progressive disease, which does respond to treatment. But we can actually see patients where we have a bad feeling. And this is one such patient. She is a 78-year-old female who had a relatively low baseline IOP of about 20 in the low 20s through her first year. Her potential corneal thickness was pretty average. Gonioscopically, she had pigment, but she was open. But she did have exfoliative material on both lenses, and she had a case of exfoliation syndrome, exfoliative glaucoma. Now it's kind of hard. She's a kind of a pale fundus. She has cataracts. She's an RGP lens wearer. She's visually very happy. She has some relatively mild disc damage with a little bit of a superior arcuate scotoma in each eye. And clearly she has early exfoliative glaucoma. Now there are some considerations here. She does have exfoliative glaucoma. It's very early. Her field loss is relatively mild. Her initial baseline pressure is fairly low. She is older. She's got this exfoliation. And the question is, can a person like this be monitored or should she be treated? And that brings me to polling question number 3, if we want to launch that. How should this patient be treated? Medical pressure reduction, laser pressure reduction, surgical pressure reduction, or close observation with no therapeutic intervention? And Greg, do you recognize this place?
I do recognize that place, and I know you have a fun fact about it too.
Yes, this is Quebec City, Canada. This is a small church that is still used for services and weddings. And it's a little square. And this actually was the backdrop for the movie Catch Me If You Can with Leonardo DiCaprio. He played the fugitive, Frank Abagnale, and he was captured in France. Well, this stood in for France. This is the square where Tom Hanks apprehended him in that movie. Very good movie if you're ever interested. So Quebec
And you have
City,
no no financial disclosure interest in that movie, right?
No, I don't. So we have a good number of responses, about half, very close, say medical pressure reduction. Others say, well, let's observe the patient very closely. Okay, I think that's excellent. Well, the patient answered the question. She declined treatment. I will caution you all, exfoliative glaucoma is probably the worst open angle glaucoma you're going to encounter. These are people who are going to have pressures that have been shown to elevate consistently over time. They're harder to control. They need more medicines, more likely to need laser, more likely to need surgery, more likely to become visually disabled. It is a very bad disease. And by such, that's why I initiated treatment when I first met her. Well, I sampled her with a prostaglandin, and she read the product insert and called me back the next day. And she's actually more afraid of the side effects of a prostaglandin that she had read than about glaucoma itself. And she asked me, am I going to go blind overnight? Obviously, no. She said, well, I'm not bothered by it. So what if we just watch it? And if nothing happens, I won't be bothered. If something does change, as long as it's not immediate blindness, we can talk about doing something. I have to admit this was an informed decision, though I tried to dissuade her because everything tells me she's going to do poorly. And I will tell you, her pressure did rise through time, and she peaked at 34 and 37. Now, exfoliative or pseudo-exfoliative, whichever term you like to use, I prefer the term exfoliative glaucoma. It isn't true exfoliation. It isn't the lens capsule peeling off. It's membrane, it's abnormal basement membrane being laid down on the surface of the lens. But as the pupil iris contracts and dilates throughout the day, it rubs that material off. So in that sense, even though it's not exfoliation of the lens capsule, it's exfoliation of this material. That's why I like the term exfoliative glaucoma. It's due to an abnormal basement deposition, basement membrane deposition on the capsule, on the iris, and it's in the trabecular meshwork. And this stuff is very, very sticky. It's like Velcro. Greg, you know what this material is like.
I do. Yeah. And I remember there was a talk at the OGS meeting where they actually took this material and tried to dissolve it in acid and bases and all types of solvents, and they just couldn't get this material to really break apart. So really a material that is just, in a sense, indestructible, I guess, from that. So
It's very sticky. It's like Velcro. Here's an early case. Sometimes you'll see that dandruff material, but I think what is more compelling here is the fact you have an abnormal pupil rough. And this is where the pigment is being released. The material and the pigment gets into the meshwork, and it's very similar to what we just discussed with pigmentary glaucoma. But when I see patients with an abnormal or absent pupil rough, an atrophic pupil rough, peripupillary translumination defects, I dilate, I see nothing on the lens capsule. This is an exfoliation suspect, particularly if they're older. Now, sometimes I'll dilate, I don't have an image, I will see radial streaks of pigment. If I see radial streaks of pigment on the anterior surface of the lens with dilation, to me, that is subclinical exfoliation. That material is creating these subclinical posterior synechial areas. And you dilate, and it will actually rip off some of the pigment, and the pigment can get caught in the aqueous convection current and cause a transient elevation. I have seen that. So I would advocate when you dilate these patients, do a post-dilation pressure check. There could be a pressure elevation. And when I say pressure elevation, an 18 to 25, nothing to be, very concerned with. And when the full dilation, we have this abnormal member. This right here, this moat, is the normal lens. This is material that's been laid down. This is material that's been laid down, and this is the part that has been rubbed off along with the pupil pigment. So it's nearly always a secondary open angle situation. Now, there are cases where this material gets into the lens zonules, makes them brittle, and actually causes rupture, and the lens can dislocate. Now, anytime a lens dislocates and moves forward, you can have pupil block angle closure. I do know of cases where this has happened to IOLs. They will dislocate. High prevalence in Northern Europeans. It's really a high altitude northern climate exposure type of thing to UV radiation. It is more common if they live above 42-degree latitude, and those in the southern tier below 37 degrees really have the lowest incidence. Greg, you're a northern fellow. Do you see this?
I do. I see this quite a bit. So
And
I see pseudo exfoliation. And Joe, just kind of sitting here thinking, there's also kind of similar findings with that vitamin D3. I wonder if there's any correlation between, that kind of, it's an antioxidant. It's been linked to lots of other conditions. I just wonder if that might be part of it, along with some other, gene expression. Just popped into my head while I'm sitting here.
That I don't know, Greg. Now, high prevalence of Northern Europeans, it has been said this generally doesn't happen in people of color. I disagree. I've seen it a handful of times in patients of African descent. Now, you think that I would not see much of it living in the southern US. I live in Florida, been living in Florida for over 30 years. But the state bird of Florida is the snowbird. So we definitely see these patients coming down. And the big key is the peripupillary translumination defects. Peripupillary translumination defects, loss of the pupillary rough, atrophy in the peripupillary region. You may dilate them, and there's nothing on the lens. It's perfectly clear. And then you dilate, on their annual exam again, and it's perfectly clear. And they dilate them a third time, and there's enough exfoliated material there to stuff a pillow. So I always consider these patients to be suspects. You know, it's this abnormal membrane material being put on the lens, not from the lens. And it behaves, very, very similar to what we discussed in pigmentary glaucoma. So really, one can argue it's probably even the same mechanism as pigmentary glaucoma. Now, it is a complicating factor in cataract extraction. It's not horribly complicating. The surgeons that I know, they'll make the exfoliate patient the last one that they do in their surgical session. There's always a possibility of loss of zonule dehiscence. They can lose it. They can lose the lens. And taking the lens out is not curable. That material will still deposit on the remaining capsule, and is really considered a general systemic disorder. It is, the material is elsewhere. It's in the ciliary arteries, in the vortex veins, central retinal veins. It's in the heart, lungs. There's a number of other organ systems where you'll find this material, and it has been associated at least weakly with central retinal vein occlusion. Other things that are possibly TIA, stroke, Alzheimer's disease, hyperhomocystenemia, heart disease. And this is a genetic abnormality on the loxyl gene of chromosome 15. Now, the loxyl enzymes are essential for normal basement membrane formation and normal remodeling of elastic fibers and preventing age-related loss of tissues, of elasticity of tissues. So if there are abnormalities in these genes, we're going to have an abnormal basement membrane. And this loxyl protein is really a major component of the exfoliation deposits and probably represents that indestructible material that you talked about earlier, Greg. So there's about a 40% likelihood of developing glaucoma through life, and usually it's because it's an older person disease. As I said, when glaucoma develops, the pressure is usually higher than open angle glaucoma. They progress more rapidly. Greg, I don't know if you feel the same way, but I've had a number of exfoliated patients where I've gotten a very good pressure reduction into what we think would be a safe level for POAG, and they still get worse. I mean, what are your thoughts there?
Yeah, pseudoexfoliation is definitely one of the tougher ones in the practice. I'm just thinking, out of everyone that I literally had to send, because I live in Western Central Pennsylvania, I have a glaucoma surgeon in the Pittsburgh area that literally does med valves and, not just like hook dual blades, MIG procedures and SLTs, but true like surgical glaucoma. And probably I'm thinking of the 5 patients that actually had to go through this procedure. They're all pseudoexfoliation patients. So it is a nasty condition that's out there. So when you have it, watch it closely.
I agree entirely, Greg. And we treat it the same as open angle glaucoma. Beta blockers, PGAs work very well. Alpha-GAN, CAIs. Again, I put a question, rho kinase inhibitors. I just don't know. I mean, we don't have enough case series and use of this drug in these conditions to know. Trabeculoplasty is a good modality, but like pigmentary glaucoma, you can have a secondary paradoxical pressure rise. Trabs and tubes sometimes are necessary. MIGS, it's usually a disease a little too severe for MIGS. Now back to our patient below us. She was a nice older woman. She refused any therapeutic pressure reduction. She had RGB lenses. She was happy with them. She was not bothered by cataract. She didn't want laser. She didn't want cataract surgery. She didn't want anything. Now, I had some long discussions with her, and I kept advocating that we use medicines to bring her pressure down. She always declined. Other than that, she was a very good patient. She came 4 times a year. I checked her pressure. I did the photographs. I did the visual fields. And this is what happened to her over the course of about 10 years. And one thing I want to point out is over the course of 10 years untreated, and this is a woman who's gone into the mid to upper 30s, she has had no change. God, I hate it when they're right and I'm wrong. I would assert that if she took medicine when I first advocated it early in her evaluation, she'd probably look the same. At least I hope she would. And I would be very confident or that I had done a very good job in treating her. And the reality was she had a very bad disease and nothing happened over the course of 10 years. So we can see, I mean, she had one bad day there. We repeated it and she was back to normal. So over the course of 10 years, she started off in 78, and, now she's over 88 years old and she has only lost a few percentage points. Now, I am not telling you to not treat exfoliative glaucoma. What I am saying is glaucoma is very individual and not every patient behaves the same. That's why we have to follow them closely. Now, at this trend, if it remains unaltered, how much more vision loss is she going to lose in the next 5 years? Hardly anything. And she'll be in her early 90s. Now, I will tell you, after about 5 or 6 years, when nothing was changing, I kind of stopped advocating the treatment. She'd come in, her pressure would be 28 or 29. She'd ask, is that good? I would say, apparently for you it is. So she had risk factors, high pressure, older age, exfoliation, yet, she didn't show any change over 10 years. Now, one day she came in and she said, she had a new concern. She had noticed her eyelashes were very thin and thready. And she heard about a medicine that can actually increase her eyelash growth. And I said, I've got a deal for you. So the irony is she wouldn't use Lumigan, but she'd use Latisse, or said another way, she wouldn't use bimatoprost, but she'd use bimatoprost. I thought I'd get away with it, but eventually she declined that as well. Now, I was doing this talk some time ago and I looked and I realized I need to update my my images, my visual field. So I went into her chart and I saw that she had missed her last follow-up visit. So I called my front desk and said, she is a bad girl, get her back in. She needs to, we need to get her back on track. And about 10 minutes later, I got a call and my front desk said her phone's been disconnected. So I did that, I commonly do in a situation that I Googled her name. The first thing that came up was a link to her obituary. She died about 2 months after I had last seen her at age 88 of natural causes, with a potentially very bad form of glaucoma for which it never bothered her even without treatment. Hence the reason we need to follow our patients closely, because we can't always accurately predict what's going to happen. Greg, any questions or comments?
Yeah, we have some questions that have rolled in here. I think you
very good.
covered it. I was going to stop you, but you were on a roll. When you were covering the pseudoexfoliation part, it says, what systemic diseases are associated with exfoliation syndrome?
And I think we got through that. You can have heart disease, you can have TIAs, you can have stroke, other vascular diseases.
Yeah, I think a comment that I'll make is that, they've biopsied various organs and tissues of the body, and they're able to find this pseudoexfoliative material. And again, as Joe mentioned, there have been associations with these different kind of vascular events, but also, really probably the most involved organ would be the eye and glaucoma. Another one rolled in here, Joe, that says, and there's two here from Peter that says, has a diet survey been done in the pigmentary patient? And then kind of the same question, whenever she had some changes there, or, did the patient alter her diet in those years? Yeah, I think we're going along the line here. Is there any, maybe some nutritional type of association with this?
I'm not aware of any nutritional associations, but that is not my forte. She did not change anything.
Yeah, I really am not aware of, the nutrition might be kind of a small player in this one, I would guess. So, as you know, I've been kind of focusing on it the last 4 or 5 years. It's certainly poor nutrition is not going to help, but I really don't think that that's like one of the major, causes of maybe like some of the other conditions that are out there that we're well aware of, that chronic low grade inflammation. I'm having a little tough with this one, but I'm going to try and read it. Maybe you'll be able to help me out. And I sent a little private message to you there, Stephanie. It says, how do you manage a paradoxical increase in IOP status post SLT in, it says odd, Joe, ODD. Trying to figure out if that's like ocular, something. How long does the increase usually last? So how do you manage the, looks like we got the reply, pigmentary dispersion. So maybe that got a little bit out of whack there. So it says, how do you manage the paradoxical increase in IOP status post SLT in the pigment dispersion syndrome? How long does it take to the increase usually last? How long does the increase usually last?
Well, first off, you can put some steroids in there in case there's an undue amount of inflammation. And then you're going to start hitting them with the aqueous suppressants. The whole idea is to get them off medicines, but now we have to put them on temporarily. It can take a week or two. Sometimes it can actually be several months, and unfortunately, sometimes it's permanent. At one of our optometric glaucoma society meetings, one of the ophthalmology glaucoma specialist speakers was advocating SLT and how much he loved SLT and how he did SLT all day long. And then later on, he detailed a case where he had a paradoxical pressure spike in a patient with ocular hypertension, couldn't control it medically, ended up having to do trabeculectomy. So the patient needed bilateral trabs for ocular hypertension. So sometimes it doesn't come down, and it's a bad outcome.
Yeah,
But
I
it's not
agree
typ-
with
it's
this.
not typical.
This is a nasty disease, right? When it goes sideways, it goes sideways. So
I've always said, Greg, lasers are perfectly safe until they're not, until you get your first complication. All right, let's talk about traumatic glaucoma, specifically angle recession. And this is a tear in the longitudinal muscle of the ciliary body. So when an eye gets hit, it's going to be compressed from anterior to posterior, and unless it ruptures, it has to move lateral. And when that happens, it's going to tear that longitudinal muscle of the ciliary body, leading to a deepening and widening of the angle. And one may wonder, well, if the angle is more open, it does look much more open, why would pressure go up? Well, it isn't the fact that it's open, it's the scarring and sclerosis from the blood, typically hyphema, and inflammation that occurs. Now, this can happen years after the antecedent trauma. As we know, a patient with, who develops glaucoma is a person whose trabecular function declines over age. Well, the angle recession patient already has a damaged trabecular meshwork. It's scarring and sclerosis. And it is not limited to the clock hours of recession that you see. It's to some degree affecting all of the meshwork. So there may not be a pressure elevation immediately or even for the first several years, but as the trabecular function declines with age, this has already been accelerated and they get it several years later. So this is a secondary open angle situation where there's a cleavage of this tissue. Now, this is one of my classic photographs and one of my classic test questions. What we see here is what appears two scleral spurs. Now, that is the original natural scleral spur. That's the trabecular meshwork. This is the ciliary body. And this is scleral tissue because the iris has been rented away. That area right there is where it was normally attached. So if you quote unquote see two scleral spurs, that's not normal. You've got to consider it might be angle recession. So we're going to be looking for, that extra layer of scleral tissue, an asymmetry within the angle or an asymmetry between the two eyes. Here is a normal scleral spur, and here is some abnormal scleral tissue that is shining through. And this is a patient who had a frank iridodialysis where biomicroscopically I could see the edge of his lens. and we look in, go endoscopically, we can actually see all of the ciliary processes. And this is his angle. And obviously, this is an angle, quote unquote, angle recession. But amazingly, there is no pressure elevation. So I said the trauma that is going to damage the meshwork, there's inflammation, and often there's hyphema. Now, it's got to be real trauma, not a scratch. I got hit by a twig. It's a punch. It's a fist, a foot, a sports ball. Racquetball fits in there very beautifully, right? Right into that orbit. It should be your first thought when encountering unilateral or asymmetric glaucoma, but understand, don't imagine, don't force it to be that. About 10 to 20% of recession patients will develop secondary glaucoma. It is not a fait accompli. It doesn't have to happen. The severity is often, but not always, related to the extent of the recession. I've seen 360-degree recessions, and at the time I saw them, no pressure elevation. I've seen 2 or 3 clock hours where they had a pressure in the 70s. So really the entire meshwork is damaged to some degree. So if pressure is normal, everything is normal, I'll observe them, but they can develop glaucoma years later because of decline in trabecular function. I tell these patients, you are at lifelong risk of developing glaucoma. If it happens, aqueous suppressants all work. Miotics and urokinase inhibitors and trabeculoplasty are kind of questionable due to the changes in meshwork. Prostaglandin analogs seem to work very well. There's a bit of support in the literature. There's not much written about it, but one will theorize if the front door is closed, if you open the back door, that should be a good thing. Now, one might surmise or speculate if the trabecular meshwork is damaged and sclerosed, wouldn't the uveal scleral meshwork also be damaged? The answer is apparently not. The trabecular meshwork is what I call a little hothouse orchid. If it doesn't get the right sunlight, temperature, and humidity, it is going to wilt. Maybe the uveal scleral face and meshwork is a little bit more robust. Prostaglandin analogs work very well. I have seen this. It is my drug of choice. Again, MIGs are questionable. If it's very bad disease, real glaucoma surgery will help. Now here's a patient with angle recession glaucoma. I saw him many years ago. I remember it very well. His pressure was 47 untreated, frequently non-compliant, and declined surgery again and again. This is how he started off. I would treat him. He would be lost to follow-up. He comes back sometime later. He looks like this. Comes back sometime later. He looks like this. And, just letting it go down. He would not go for surgery. One medicine, covered by insurance, no side effects, worked very well. And I thought it got through to him and his wife. I showed this to his wife. She was there in the exam room. She said, "Oh, he's going to be using medicine from now on." And that was the last time I ever saw him. So why he let it go, I just don't know. Or I've got a theory. And here's another case. I call this Miss Daisy driving. She has angle recession left eye from blunt trauma several years earlier. Coincidentally, also pressure 47. And she'd come in when her eye hurt or her vision got blurred because her pressure would go up. She'd get corneal edema. She had hyperemia with Travitan Z. I sampled her with Zioptin. Did better than it was more tolerable, still a little bit of hyperemia. And I scheduled her for a 3-week follow-up. She presents promptly 11 months later, having used only 3 drops of Zioptin, and this is what she looked like. Greg, do you think she got worse?
Just a little bit. I'd say mild progression.
That was over the course of about 11 months. Now, interesting what she used to tell me. I thought this is kind of amusing. I call this, driving Miss Daisy or Miss Daisy driving. She would tell me she'd like to try to drive with her. She'd cover her right eye just to see how well she could drive with her left eye, and her left eye looked like that. Greg, what's your thought on that?
Yeah, that wouldn't be a good with that. Yeah, if that's a true visual field defect, that really wouldn't be that good. So
Yeah, and she told me she would close her right eye and drive as long as she can just to see how well she could do it. I guess there are many ways to control pressure. Medicines, laser surgery, and I guess death are the best ways to control it. But this led to my clinical pearl that I've always said, and this is a Salcaism. I think the trauma that causes angle recession also seems to cause brain damage. Greg, any questions in the chat room?
no, the last one we had was taken care of.
Okay. Well, let's move.
Hold on. As we speak, 8:08, one rolled in. Do you send certified letters to these people that don't follow up, or do you just document attempts to schedule appointments? And that's a pretty good question for Joe, as Joe does the medical errors and jurisprudence for Florida. So, Joe?
Yeah, the answer is doing that is good care. Is it necessary and what the majority of people would do? Probably not. And I will tell you, an attorney can argue or defend virtually anything. And I'll give you an example. We were talking about, because when I was at university, we would occasionally have a seminar by the law firm that handles our affairs. And they would talk about medical malpractice. And he was talking about, he was presenting a case where a patient never followed through and the doctor was negligent because he or she didn't send a certified letter, she didn't call, they didn't do this. And the question came up was, what happens if you're defending the doctor? And without pausing to take a breath or change inflection, he goes, what more can he do? He made the appointment, patient didn't follow through. The answer is, I just document it. Now, if you are really worried, if it's one of those things that you think they're going to go blind from giant cell arteritis, or they have an intracranial aneurysm, the more aggressive you can be, the better. But we can't follow every patient like that. We just document what we do. Everything that you do on their behalf, document, and that is your best defense. Well, here's a case of the snowy referral. A 21-year-old Hispanic female was referred to me for elevated intraocular pressure. That's all she knew, and she had no referral note. Now, she did complain of snowy vision for the past few months, was getting worse. Ocular history is unremarkable. Medical history, she had asthma diagnosed a few years earlier. She was 20/70 in each eye. She pinholed down to 20/40 in each eye. So it looks like your best corrected is about 20/40. She has no afferent defect in either eye. Gonioscopically, she's open to ciliary body 360 degrees without abnormalities in either eye, no pigment, no neovascularization, no angular recession. And her pachymetry is very thick in the 640 range. So here are her photographs. We can see is a relatively dull area inferiorly. You can certainly see the choroidal vasculature inferiorly better than we can superiorly, telling me that there's probably a very broad area of neurofiber layer abnormality inferiorly in each eye. We take a look and we can see that her OCT shows this abnormality in her neurofiber layer inferiorly. Her ganglion cell complex is not really that robust in either eye. We can certainly see a bit of a cut in the horizontal, what I call that nautilus shell appearance. And these are her visual fields. And they're reproducible and they seem to match very well her neurofiber layer defect. So here we have this 21-year-old female with the best corrected visual acuity of 20/40. Biomicroscopically, she is normal. She has clear corneas. She has visual field defects that look like this. Oh, by the way, I forgot to mention her pressure is 72 in each eye. Greg, that brings me to polling question number 4. What is the most likely diagnosis? Angle closure glaucoma, Posner-Schlossman syndrome, primary open angle glaucoma, steroid-induced glaucoma, or some weird systemically induced glaucoma I learned in school, but I can't remember right now. And Greg, do you recognize this visage?
I do. That's a great picture too. Good job. That's
That
Mackinac
is
Island. That's
Mackinac
Mackinac
Island.
Island. Yeah.
That is the Mission Point Resort. Beautiful place, especially in the summertime, as Greg mentioned. No cars, foot, bike, and horse-drawn carriage. And Greg, do you know what movie was filmed there on Mackinac Island? Very famous movie from the 80s.
Oh, I'm sure you told me, but I didn't retain it in my cortex. So
And that's why I keep repeating myself again and again, Greg. I want you to absorb it. Somewhere in Time
somewhere in time.
with Christopher Reeve. Did you see that movie, Greg?
I did not.
Don't worry, I don't think anybody did. All right, I think we're
let's
doing
see.
well.
Yep. I'll share these results in a second.
All right, all right, all right. So angle closure, Posner-Schlossman syndrome, primary open angle glaucoma, steroid-induced glaucoma, some weird systemic condition I learned in school, but I can't remember right now, which is always really good, always a very good answer. Well, I did say she was open to ciliary body. Posner-Schlossman can go into the 70s pretty easily. I've seen it before, in fact, several times, but it is typically bilateral. This is a unilateral situation. Her angles are open. I didn't give any history of steroids. So let's go on. So I'm gonna tell you, it was steroid. Her lens was the key diagnostic feature. Okay, she had 2+ PSC cataracts. That was her snowy vision. So here we are, a 21-year-old, 72 pressure, glaucomatous damage, PSC cataracts, and I'll show you something. I mean, I had the benefit that you didn't have. These are not the patient. These are images from the internet, but they were telling. They're very telling. She had that round moon face. She had that fatty deposit on her between her shoulders. The buffalo hump. She had Cushing's syndrome. And when I asked her about that asthma, she was self-medicating with intramuscular dexamethasone 2 to 3 times a week that she got imported from Honduras via the internet. She also had weight gain, hair loss. You know, I asked her, you know, if she had gained any weight, and her partner was sitting there and said, "Yeah, I hate to say it, you gained about 40 pounds." She had hair loss. Ultimately, I had to send her to an endocrinologist where she was diagnosed with diabetes, and she gave herself iatrogenic Cushing syndrome. Now, this is not a situation we can just stop the medicine. You know, she has shut down her adrenal cortical axis. This is one of those rare conditions where glaucoma can be fatal. So ultimately, I had to get her urgently to an endocrinologist who actually put her on steroids, put her on oral prednisone to taper her off the injection. And of course, you know, she was diabetic at that point as well. But this is steroid-induced glaucoma, secondary open angle situation, and it is an outflow difficulty. The steroids are changing the trabecular meshwork's ability to process aqueous. Glycoaminoglycans, the sticky glycoprotein, is accumulating in the meshwork because steroids are preventing release of enzymes that normally depolymerize the glycoaminoglycans and cleans up the trabecular meshwork. So this prevents the trabecular meshwork endothelial cells from keeping the meshwork healthy and clean. So this is an outflow difficulty, simply that GAG accumulation. The steroids are inhibiting the enzymes that break down the GAGs, the glycoaminoglycans, and it prevents the endothelial cells from cleaning up that meshwork. So it is an outflow difficulty. Most commonly are prednisones, dexamethasones, betamethasones, difluprednate. Difluprednate is a great steroid. I mean, I think it's probably our best steroid. It will affect IOP faster, within a week or two. And probably more significantly, I've had patients go into the mid 30s to mid 40s, but it doesn't have a greater prevalence than prednisone. And a really nice meta-analysis paper came out in one of our optometric journals by an optometrist. I don't remember. And they actually looked at cases of difluprednate causing pressure elevations. And one of the cases that they had examined was a case that I published earlier. And they came to, I thought, was a relatively elegant conclusion was the people who are having difluprednate pressure elevations were ones that were overusing it. When we treated Durezol like we treated prednisolone and use it every hour while awake, 3 to 4 times with the potency of this is generally acceptable. And in my case, I had overprescribed the medicine for a scleritis. It worked, but it gave the patient a pretty high pressure elevation. And their conclusion, this was an optometrist in an optometric journal who had written this meta-analysis and came to the conclusion that if we overdose it, we're more likely to cause it to happen to Durezol. Otherwise, Durezol is a pretty safe medicine. Any steroid can elevate pressure. Loteprednol is considered a soft steroid. There's no safe steroid or soft steroid. They can all cause pressure to elevate. Greg, any thoughts?
The only thought that I'm going to have, Joe, is kind of echo what you mentioned about this patient. This is a patient that you're going to come in, you're going to say the pressure is 72 in your eye. You created yourself to have cataract. Take a look at this visual field defect. And, we're going to scare this patient to the point where, oh my gosh, what did I do to myself? I'm going to stop these injections where, like you said, we don't have any steroids being produced from the adrenal glands and the cortex from those adrenal glands on top of our kidneys there. So the last thing that you want to do is make sure that, make sure the patient doesn't stop until you get them to the endocrinologist. I just don't want that being taken lightly. That is definitely worth echoing.
That's a great point, Greg. And truth be told, you may never find a patient that is doing something like this to themselves, but one never knows. Response, the pressure response, 2/3 of the population are steroid responders to some degree. I know that we were taught that 1/3, but really 2/3 respond in some degree, but only about 5% will actually get in trouble with a pressure over 30. And of course, the response is dependent on the dose, duration, and frequency of application. And of course, the genetic predisposition. People with glaucoma are more likely to steroid respond. Another population more likely to steroid respond, children. Be very careful with pressure in children when you put them on steroids. And unfortunately, based upon duration, sometimes simply stopping the steroid will not allow the meshwork to bounce back, and they may actually have a permanent glaucoma. So treatment, obviously, if you can, stop the steroids, but it may not come down. Now, aqueous suppressants are going to work. Prostaglandins, depending on how much inflammation and what steroid they're using. Mostly it's steroids in the eye, drops or ointments. Yes, oral steroids long-term, high-dose IM steroids, IV steroids can do it. Mostly it's the topical use. So really anything to enhance outflow, will likely have a poor effect on these patients. Now with her, I used multiple medicines in a relatively short period of time, but I couldn't get her pressure under 50. So, she went to the endocrinologist. Ultimately, I think she ended up with glaucoma surgery as well.
Yeah, I have a comment to make,
Okay.
regarding the loteprednol. And you are 100% accurate, but again, at least worth echoing is that, because, of the ester side of that steroid versus the ketone side of the prednisolone, We have plasma cholinesterase, and it can break down. And the whole idea is you're using the chemistry of the eye, and it breaks it down, and it doesn't penetrate, so on and so forth. But if you think about recently what the newer lodiprednals that came out with, they're submicron. And on top of it, they made it slipperier. They wrap it in that, nanomicellular envelope to allow it to get through the mucus. So the steroid is still the steroid. All they changed was that, I think it's the carbon 20, change it to an ester to allow it to get broken down. But the key is we want to get it to the tissue. So they made it nano size, able to diffuse, able to penetrate. And when you get the penetration, and that steroid can do that, that chemistry that Joe talked about with the gags at the trabecular meshwork, you do get a pressure spike. So again, don't think that, and just want to echo what Joe said, don't think all steroids are safe. I think even especially with the new technologies out there, we need to be a little bit more careful with some of these lodiprednals.
Excellent comment, Greg. Thank you. Oh, here's a case of 28 days later. And I'm not sure if anybody saw, my reference. There's a movie several years ago called 28 Days Later. It's actually a pretty good horror movie. It's one of the first genre of zombies that hustle, or fast moving zombies. So if you never saw that, it's a good watch. She's a 50-year-old female for a comprehensive eye exam. She's 2200 and 2040 with a much worse cataract in her right than left. She had been sent for a cataract consult when she saw the ophthalmologist. Pressure was, or the vision was 2400 and 2050. And that could just easily be just the difference in charting. And she was considered not a good candidate for a cataract extraction because she had some corneal and retinal scarring from an old rubella infection. So she was not scheduled for cataract surgery. Now, 28 days later, she calls complaining of rapidly decreasing vision in her right eye and pain. Now, she's light perception in the right eye. Her pressure is 32. She has a moderate anterior chamber reaction. Her angles are open, and she looks like this. And what we see here is a very dense cataract. Now, interestingly, at her first examination, her fundal details were well described. In the ophthalmology consult, her fundal details were also well described. 28 days later, when I'm seeing this patient, I can't see anything beyond that lens. That's like trying to look through a brick wall. It is dense, and I'm not seeing anything there. And she's got what we call a classic great white cataract, hypermature, and it is beginning to leak out, creating an inflammatory response. Or rather, she has a lens-induced glaucoma. There are a number of ways the lens can induce glaucoma, and several are actually very similar. There's phacolytic, phacomorphic, lens particle, phacoanaphylactic, and ectopia lentis. Now, phacolytic, lens particle, and phacoanaphylactic, also known as retained lens fragments, are essentially the same mechanism. In phacolytic glaucoma, a hypermature lens develops an attenuated capsule, becomes very soluble, and starts to leak. When this happens, high molecular weight soluble lens proteins gain access to the anterior chamber. Now, even though it's the patient's own tissue, these proteins have never been in the anterior chamber. They've always been enveloped by the capsule. So they are recognized as being foreign, and it initiates an antigen antibody response. Where these macrophages are released, they phagocytize these heavy soluble lens proteins, and they tend to settle out in the trabecular meshwork, causing inflammation and physical blockade, and we subsequently get a pressure elevation. So this is a lens-induced uveitis. And the same thing is happening with lens particle, except there's lenticular trauma, such as a penetrating injury, or phacoanaphylaxis, where lens fragments are not evacuated from the anterior chamber. It creates this inflammatory response and often a secondary glaucoma. So these proteins are leaking out through this attenuated capsule, and there's liquefaction of the lens cortex. So you get this flocculent material in the chamber on the lens surface. And these macrophages are becoming very bloated. They're settling out, and they are causing, a blockage of the trabecular meshwork. Now, polymorphonuclear leukocytes, plasma cells, lymphocytes, they're typically absent. You're not often going to get much synechia. You don't get much posterior or anterior synechia. It's not a sticky uveitic response. Obviously, this is cured by lensectomy and possibly even vitrectomy, depending on the amount of vitreous involvement. But there's always the possibility of capsular rupture during surgery, and that will require now a vitrectomy. You can lose the lens. Sometimes that the zonules are not intact, and the lens actually may be loose and can be lost during surgery. Now, medical therapy is initially used to temporize the pressure and quell inflammation in the same way we treat uveitis. Corticosteroids, depending on the severity, obviously. Cycloplegia, unless you think there's zonular damage or a danger of subluxation. Now, how do you know if there is? Look at that lens carefully and have the patient move their eye subtly. If the lens moves, phacodonesis, it's probably not a good idea to dilate them. Beta blocker, alphanergic agonists, CAIs are all acceptable. The prostaglandins aren't going to hurt. Miotics could worsen the situation. And I don't know about the rho kinase inhibitors. And this is a nice example of what I mean by the safe to dilate patient. Is this patient safe to dilate? This is a patient, 65 years old, pain and poor vision, light perception, a pressure of 35. She was phacolytic. That right there is not a shadow. That's actually the edge of the lens. So her lens had already dislocated, and as she moved her eye, there was phacodonesis. The lens actually jiggled. I said, do not dilate this patient. Get him to surgery, and ultimately, when surgery was done, there was no zonular attachment whatsoever. They actually had to do an extracapsular cataract extraction. Here's the case of you're wrong. No, you're wrong. This was a 65-year-old female who had been seen with a dense cataract and referred for a surgical consult. And based upon suspected pre-existing ocular abnormalities, was deemed not a good candidate for cataract surgery, so it was deferred. Then she comes back a year later for a comprehensive exam, sees one of my residents, and the resident and patient got into what I would euphemistically call a spirited debate. The resident's issue was the patient insisted she had never had cataract surgery, but she had no lens. And the patient said, I did not have cataract surgery. I would think I would know that. Both are insisting that they're right. And this is what she looked like. The resident had actually done the evaluation prior to dilation and saw no lens. And she was right, there was no lens. But the patient was also right, she had not had cataract surgery. That was the residual lens right there. The eye was digesting her lens. And that is the phacolytic response. It's an evolutionary response to blindness from cataract. If the inflammatory response will digest and degrade it, it will give them vision back, albeit aphakic. So the patient was right. She didn't have cataract surgery. And the resident was right. She really kind of didn't have a lens. And this was the phacolytic response. Greg, any thoughts here? Any comments about lens-induced? Any questions coming to the chat room?
Nope. Just someone made a comment. Could this be phacolytic glaucoma? And it was. And no other comment or no other questions. Oh, let me scroll down to make sure. Yep, no other questions. And I don't have any comments.
All right. Well, the next one, Greg, and everybody listening, is the challenge that if you
Oh,
understand
hold
this.
on,
Oh,
hold on.
okay.
We got a question. What
You
was
really
her
know that.
IOP?
This is not a good question. Actually, her ILP was normal. So the inflammatory response was pretty much kind of winding down. I don't think she really had many cells in the anterior chamber at that point. That's a great question. What was it? That's the problem. It's an evolutionary response, but unfortunately, it can blind the eye from glaucoma. So it's not a good evolutionary response to cataract formation.
And I'm
Now
assuming,
this,
Joe, that had a high hyperopic, like a plus, 12 to 18, like refractive to try and get any vision.
exactly.
Right.
Yeah,
Okay.
because she was essentially now aphakic.
Yeah.
Here's a case. I'm going to say, if you understand this, you really know glaucoma. This is not an easy one. It's what I call the case of the routine eye exam. 50-year-old man comes in for a comprehensive eye exam, in our general care clinic. He's 20/40 in each eye. He is a very high myope. He is 18 diopters myopic with some cylinder in each eye. His pressure is 42. He has constricted visual fields on confrontation, and advanced glaucomatous disc damage in each eye. And here are his optic nerves. And I looked at this patient undilated. I put everything together. What is the next thing should be done? Greg, when you have a patient with pressure in the 40s, what's one of the first things that you like to do as part of your initial evaluation?
Pressure in the 40s, definitely want to check the angle out, do a little bit of history, see what type of medications they're taking. Double back on, what could be causing this pressure to be in the 40.
I think that anytime that I have pressures in the 40s, one of the first things I'm going to do is I'm going to do gonioscopy. Doesn't hurt. And one may say, well, hold on, he's a -18 diopter myope. Those are not the kind of patients that are going to undergo angle closure. It's usually that moderate hyperope, and this is an 18 diopter myope. Now, when I looked at the patient, I saw his refractive error. I did do gonioscopy, and he was closed. He had a chronic angle closure. Now, the answer, my friend, is not blowing in the wind. It was actually staring us in the face. And it's not so much what you see, it's what you don't see here. There's advanced glaucomatous damage in each eye, obviously. But what's missing on an 18 diopter myope? There's not a myopic fundus. There's no staphyloma. There's no evidence of myopia here. That's a fairly large nerve. And when I put non-myopic fundus in concert with a highly myopic refractive error, that tells me everything is due to his lens. And that's what he had. He had a very small, round lens. It actually protruded a little bit into the anterior chamber. And he had phacomorphic glaucoma from isolated microspherophakia. And this is what he actually looked like. You can actually see his lens protruding into the anterior chamber a little bit. And he had phacomorphic glaucoma. Phaco lens morph shape. It's the shape of the lens. This is actually the most common form of lens-induced glaucoma that we have. It's a secondary angle closure with pupil block. All right. You have a unilateral or asymmetric cataract, leads to relative pupil block, shallowing of the chamber, angle closure, no other factors. Now, sometimes it can actually be difficult to differentiate from primary angle closure. It's a patient usually with an intumescent lens. Often the vision is significantly reduced, not always. And it's increased lens thickness through cataractogenesis. You have growth of the lens cortex, intumescence of the cataract, relative pupil block. It may be associated with a short axial length. But cataractogenesis is an important cause of angle closure. Now, in this situation, my patient did not have a cataract. He had a very unusual abnormality called microcerophakia. And this is uncommon, but not necessarily rare. Angle closure, high myope, you've got to consider microcerophakia. It may be an isolated phenomena involving only the eye, or maybe associated with Weil-Marcesani syndrome or Turner syndrome. And this presents as acute or chronic angle closure in an eye with that is highly myopic. When I did his A scan, ultrasound, biometrically, he had a slightly hyperopic eye in structure, even though he was 18 diopters myopic. Now, in these patients, obviously, taking out the lens is the best thing if it is at all possible. In temporizing the situation, any of the aqueous suppressants should work very well. Prostaglandin analogs also work very well in chronic angle closure. Pilocarpine corticosteroids can be used if there's acute inflammation. Ultimately, lens extraction, if possible, is the best thing to do for these patients, or any lens-induced glaucoma. Anything coming, Greg?
Yeah, we had a question roll in. It says, also a concern in using Pilo Vuity with those who have spherophakia, in parentheses, angle closure is possible.
Is it possible for the Vuity to cause it? It probably would not. In fact, in those type of angle closures, using a miotic can be beneficial. And again, microcerophakia, uncommon, but not necessarily rare. Diagnosis, angle closure to high myope. That's your answer.
And then, the other part to that would be if they're going to be myopic, maybe you'd have them in contact lenses and maybe using Vuity, but Vuity is mainly for kind of that plano, presbyope that's out there. So,
Greg, I'm going to call this the case of the found dinosaur. 63-year-old male complained of veiling over his right eye for about 2 days. He's 20/40. He had a history of lasered retinal tear, so he's always cautious, or always very worried about getting a retinal detachment. He's worried he's having a retinal detachment. Now, cataract removal of capsulotomy about 15 years earlier. And indeed, I had old records in his chart that, he had capsulotomy with cataract extraction, each eye. Now, initially, when I looked at him, behind the intraocular lens, there was a pacification. I mean, it looked like a very dense capsule, but he did have a history of having a gag done. He also had a grade 2 anterior chamber reaction with these like little white, kind of heavy inflammatory cells, and his pressure was 32 versus 15. And this is what he looked like when I dilated him. What that is right there is retained lens fragment. He's got retained lens material. And this was about 15 years after cataract surgery. And I said, it's like finding a dinosaur. Like, where was it hiding? And sometimes this material can actually be up between the capsule and the IOL there. And he was playing tennis and he actually shook it loose. And it started an inflammatory response, and this is a phacoanaphylaxis. So while this is usually happening very early after cataract surgery, be aware sometimes that material can hide and it gets into a protected area and may manifest years later. All right, I think we're getting close toward the end. I'm going to call this the case of the disappearing diabetic. 82-year-old Hispanic male comes for a pressure check. His last eye exam was 2 years ago. I've been lost to follow-up. History, he had glaucoma, left eye, both eyes, but left eye was a severe stage. Pseudophakia with IOL implantation about 2010. He had capsulotomy in the left eye 2010. He is diabetic. Medications, latanoprost and glyburide. Chief complaint, ocular pain and redness of the left eye that started about 15 days earlier. So he's 20/25 in the right eye, no light perception left eye. He's got a relative afferent defect in the left eye, a very injected eye in the left eye. Microcystic corneal edema, I should change this, I'm sorry, it should be left eye, everything is left eye. He had diffuse neovascularization of the pupil margin in the left eye, chamber deep and quiet in the right eye. He had about a 1/10 hyphema with red blood cells circulating his anterior chamber in the left eye. I really couldn't see anything in the left eye posterior to the lens. His pressure was 23 in the right, 62 in the left. And gonioscopically, he had peripheral anterior synechia and hyphema in the left eye. And this is what it looks like. We have a very cloudy cornea from microcystic edema. Whenever you see microcystic edema centrally, post-cataract surgery, whatever, always check the pressure. It's most likely an acute pressure elevation. And we can see here his layered hyphema, gonioscopically. He was pretty much closed for the most part. I saw some areas of hyphema, I saw areas of some neovascularization, but generally speaking, he was closed. So approaching him, it's certainly not an urgency. He has got, neovascular glaucoma. Cerebral again, atropine, pred forte, and continue the latanoprost. Send him for retinal evaluation. When he goes about 2 weeks later, his pressure is now 26 from 63. They can see into the eye a whole lot better. He's got an old central retinal vein occlusion. Cornea had cleared. There's a better fundus view. Ultimately, he underwent Avastin injection and followed by pan-retinal photocoagulation. So this is actually neovascularization of the iris and angle leading to a secondary angle closure without pupil block. Aqueous can get from the posterior to the anterior chamber, but it can't get out. There are many possible causes: diabetes, carotid disease, retinal vascular occlusion, vein occlusion, real common cause. CRVO, very common cause. And essentially what happens is there's ischemia to the retina. And when that happens, the hypoxic retina starts releasing these 6 polypeptide proteins, VEGF, and it will diffuse forward because there are no viable capillaries in the back of the eye from which to bud neovascularization. So it reaches the posterior iris, causes blood vessels to grow. It grows through the pupil, across the anterior aspect of the iris, into the angle. And these blood vessels are supported by a very sticky collagen vascular tissue that supports it like a scaffold. And it's very sticky. It'll cause the iris and cornea to zipper shut together. So it's a zippering shut of a secondary angle closure without pupil block. There's often a lot of inflammation and a significantly high pressure. The prognosis is actually very poor because there is not only the glaucoma, but the underlying ischemic retinal condition to begin with. It is often poorly responsive to medical treatment. I've often said, you don't chronically treat these patients medically because it's like arranging deck chairs on the Titanic. You're making it look better, but it's still going to sink. It's often called the 90-day glaucoma because it occurs within 90 days. Don't be fooled. It can occur a lot sooner. And what you're looking for is this fine, wispy, red hue in the pupil margin. By the time you see this, there are vessels in the angle as well. We don't need anything as grotesque or obvious as this to understand we're dealing with neovascular glaucoma. And, once we see this, we know at this point there's hyphema. The angle is virtually zippered shut. But look for that red hue right along the pupil margin. It's very, very, and sometimes you only see a few specks of it. So inspect that pupil very, very carefully. And that brings me to polling question number 5. And Greg, I know you recognize these characters.
I do.
Yep.
I see Mason there now, the true Mason. I see Pinka and Roscoe.
Yep. And
So
when
Joe,
Greg-
while this polling question is going off, I kind of want to talk a little bit about that microcystic edema that you see sometimes after cataract surgery. And what I've learned over the years after doing, hundreds of post-ops is, sometimes you get a pressure spike and sometimes you don't. And the ones that, that typically got that pressure spike after cataract surgery kind of have that whole diffuse microcystic edema across the cornea. And there's sometimes where you have the cornea where it's clear around the edge, 360 degrees, a couple millimeters, but then you kind of got that central microcystic edema. And I really didn't figure it out what was happening there until I went into surgery and watched the surgeons. And sometimes that surgeon likes to take that lens after the capsulorhexis is done and bring it up into the anterior chamber. And that's where they'll phaco it. And so you get that little phaco edema, but it keeps that clear ring. Joe's right. You're going to check the pressure on everyone, but those are the ones that get kind of the phaco edema, microcystic edema without the pressure spike. The ones that I've learned over the course of the years of doing it, the ones that have that diffuse kind of limbo to limbo, usually the ones that have the pressure spike because they got the microcystic edema from having a pressure of 40 or 50 overnight from the cataract surgery. So a little bit of, CSI there when you're doing your examination. Looking at the microcystic edema, you're going to check it no matter what, but you're probably not going to see the spikes on that central one.
All right. So which medication is typically not necessary in neovascular glaucoma? I hear atropine, beta blockers, steroids, miotics, carbonic anhydrase inhibitors. And I think that the majority of the audience got it right. Miotics are pretty much not necessary. You're going to mobilize that iris and probably cause more bleeding. Now, is it going to hurt? It's kind of a bad disease to begin with. But what I want to share with you is the typical treatment. Neovascular glaucoma is a very bad disease. It's got a very poor prognosis. However, if you follow a simple algorithm, it's actually very manageable. So initial medical treatment, cycloplegia, and yes, you need it. And the recommendation is atropine 1% twice a day. You're going to put that ciliary body at rest. You're going to make the patient more comfortable. Doesn't matter in angle closure. It's not pupil block. It's needed. It's Predforte or a similar steroid for the inflammatory component 4 times a day should be fine. Aqueous suppressants can also be done to temporize the pressure. As I said, in 2 weeks, I brought her from 63 down to about 23. And it allowed the surgeon a better view of the fundus. But again, you don't chronically medically treat this type unless there is absolutely no visual potential, but they need more definitive treatment. What is the more definitive treatment they're going to get? They're going to get anti-VEGF injections. Anti-VEGF injections do wonders to cause vascular regression. That being said, when their effects wear off and they are ephemeral, the problem comes back. Ultimately, pan-retinal photocoagulation is going to destroy that ischemic retina to reduce the vasoproliferative influences that are causing that neovascularization to go. Of course, there are other things, trabeculectomy, cryotherapy, cyclodestruction, but basic neovascular glaucoma management is atropine, steroid, aqueous suppressant. It's not an emergency. Get the patient to a retinal specialist. They're going to undergo an intravitreal injection, pan-retinal photocoagulation. And that is about the best that you're going to do. Now, Greg, we got into some really good discussion. I think everybody, I think the questions were great. Our discussions were I always enjoy talking cases with you. I ran a little short on time, but we are at our time. So rather than trying to push on, I'm going to say we probably have covered a lot of good stuff. So with that, I'm going to say we're about done. So let's just call it right here.
Sounds perfect, Joe. I don't see any other questions. I see Dr. Shovelin made a comment regarding the pseudophakia is not referring to a specific case, of course, just mentioning the possibility seeing case reports being used with pilo in patients with spherophakia. So just wanted to make that comment. Joe, thanks for taking secondary thoughts on secondary glaucomas. Not an easy topic to tackle, but in a nice, logical, systematic, and case-based is what we try to do at OEC. So thank you for doing that for this interactive distance learning course. Thank you, everyone, for attending. This will end the CE. And Joe, you're getting your virtual round of applause there. If you want to open up the chat box saying thank you, excellence, and thank you. I want to remind everyone that we have upcoming interactive distance learning courses. I'm going to be doing amniotic membranes and biological agents for the eye coming up on April 5th. Note the time, 8 p.m. on all these Tuesday. We weren't able to pull off any Sundays for April, so they're all Tuesday for April, 8 p.m. to 10 p.m. We've been getting some requests for kind of the other time zones other than Eastern. So we just moved it to 8 o'clock. And then on Tuesdays, we had some requests on the Eastern side for that also. We have a meeting with the whole OEC team on Tuesday. We'll pick out the May, the June, July dates on that, and you'll see them posted. We are going to continue to do interactive distance learning through 2022. The interactive distance learning course, nothing's changed here. I think Joe mentioned it earlier. Please check with your states. I did cross through, Joe. I struck out as I promised. Looks like Florida is remaining to be live and in person. But also it doesn't mean with all these states that are struck through that you can get every single credit. Please check with your state boards regarding that. Here are our upcoming live events. Don't forget, we also have Enduring CE for those who just want to take it. And we also have, I believe, the narcotics course on there. Our lineup will be the Sunshine State coming up in June. That's down in Florida at the Orlando World Center. We have Mackinac Island. We keep talking about that. That one's trending well. So if you're going to go to that, make sure you sign up because we did sell out last year. The hotel is limited, and we will be going to Nashville in October. The 2023 lineup, we will be going back to Scottsdale. We're determining the date and location of the hotel. The Northern Escape, yes, we still have that on, but we want to make it easier to get it back and forth across the border. So stay tuned. And we had to set Strasbourg to the side. It is canceled for 2022, but watch for 2023 as we're doing that in conjunction with the Rosenberg School of Optometry. And then housekeeping, Wise Guys is what's on the credit card. It's not optometric education consultant. Post-event emails, you'll get one tonight, probably in about 4 minutes. We'll have the survey in it. Please complete it. We'll also have the handout. Next 1 to 2 days, a certificate of attendance. If you're taking this, we do have some auditing options, but if you're taking it for credit, you'll get that certificate in 1 to 2 days. Also the replay and the post-event survey. We have Daisha on tonight as our COPE administrator. Daisha, thank you for being here. I see you up there. Any questions or comments or just a thumbs up? You all good? All right, we get the thumbs up from Daisha. Joe, I know I went through those slides pretty quickly because we like to be finished here at 9, but anything, comments regarding all those previous slides? I'm going to say thank you for doing this. It was a great pleasure here tonight working with you. What other comments you have, and I'll let you land it.
No, I think you've handled everything for 2023. You did mention possibility of Strasbourg, mentioned the possibility of Quebec City, but we will, of course, be in Scottsdale or the Phoenix area. We will be in Mackinac Island in 23. We'll be in Nashville in 23 as well, and somewhere in Florida in 23.
Joe, you've been putting up a few things on Australia. Is Australia still on the radar?
That's always a possibility. I think we'll have to discuss that to see if anybody wants to go to Australia with us, mate.
Okay, perfect. We'll have white slides, much more legible. Okay, we'll take that as a. All right. Thanks everyone for being here. We're going to end the presentation. Joe, you're just getting your virtual thank yous.
All right, very good. Thanks, everybody. Peace and love. Peace and love.